another question here on the middle of the floor. So.
Okay, this goes to Dr. Kyba. Okay. Oh, sorry. I know doxycycline is commonly used to treat bacterial infections such as Lyme disease, like acne, rosacea, and other types of infections and stuff. I know you were doing work using doxycycline, but does taking that medication, does it increase the symptoms of producing more DUX4 and causing more progression of the disease?
No. And I hesitated to give too much detail in the slides, even to mention doxycycline as the method of turning it on for that reason. It's, we've engineered the cells to have something in them that senses doxycycline and then turns on the gene that we stick in, whether it's DUX4 or, as you saw, all the other FSHD candidate genes. So it's only in these cells that have been engineered to have this doxycycline sensor and then also engineered to have a copy of DUX4 that's sensitive to this doxycycline sensor where the doxycycline works. We could have used other chemicals. There's a number of different approaches that work the same way. But the short answer is apologize if I gave you the idea that doxycycline affects DUX4 in the normal case. It's only in these engineered cells that we've made that it does it.
I have two questions, one for Dr. Tapscott and one for Dr. Kyba. Over here. Okay, so for Dr. Tapscott, if we hypothetically have some way of fixing the muscle cells, make them well-behaved and ignore the DUX4 or whatever, and start repairing themselves and doing everything that healthy muscle cells do, how will we deal with the fat and the fibrosis and the scar tissue that formed over the years in a patient? Okay, that's the first question. The second question for Dr. Kyba is when you use a compound to suppress DUX4, if you provide it through, say, the bloodstream or something like that, it will go into muscle cells but also into the testicles, where you probably don't want to suppress DUX4. Or, I mean, what would it do to the patient? So these are my two questions.
Can I take the second one?
You want to switch?
You know, we've all been talking to drug companies, and I always say that if you get a male infertility pill, what a nightmare. No, that's to answer your first question, you're bringing up an important point not only for FSHD but for many of the other muscular dystrophies in terms of at what point will treatment be effective. And the answer, I think, is, you know, we can only speculate to the extent that the earlier you treat, probably the more effective the treatment will be. I'm a little bit encouraged by some of the mouse models of not FSHD, but myotonic dystrophy or Huntington's disease, where you have a reversible genetic lesion that causes the disease. That it's been very surprising to me how much you can reverse late events, but it's an open question.
So for number two, the question, you raised it with regard to finding specific inhibitors of the DUX4 protein, but it would also apply to any method of shutting off DUX4. I imagine it would apply to epigenetic methods of shutting off DUX4 that might be active in the testes as well. So the short answer is that we just don't know. There's no evidence that DUX4 is actually necessary in the testes, and the normal way of testing whether a gene is necessary in a particular tissue is to take an animal model and then remove that gene from the genome of the animal. And so, as you may know, mouse has a similar gene array called DUX, But there are pretty significant differences between mouse and human ducts, so different enough that we can't actually say that they work the same way. They probably, with regard to the testes, they may even work in different ways. So simply doing the knockout of that gene in the mouse won't answer the question. So, you kind of brought up a very important point. Whatever method we use to inhibit this locus and prevent DUX4 expression, it may prevent the damage in muscles, but it may also have unintended consequences. My personal suspicion is that DUX4 is probably not doing an essential job in the testes, but it won't be known until it's tested.
All right, I guess the questions from the internet are next. We have three. One is from Mo. He has a question about pain. And in his family, some people have pain, other people don't have pain. They've recently started, under advice from their doctor, using diclofenac. I'm not quite sure how to say that. And his question is, is there any information as to how common pain is, and whether there are any other good alternatives to NSAID or diclofenac for pain relief?
I guess rather than, I think there's some clinicians in the audience who treat FSHD. Maybe Catherine or Baziel would be better able to speak to that either, or now, or I'm sure it'll be addressed tomorrow as well.
Okay, we can leave that to tomorrow. Linda had two questions. One was for Dr. Tapscott, that you mentioned the potential use of lifestyle, diet, and exercise to affect DUX4. She wondered if you could elaborate on that. And her second was for Dr. Belayew, and whether or not Alexandra was aware of Langevisi's work at Montpellier on a supplementation study, and whether she has any insight or thoughts on that study.
Yeah, just very briefly to also echo, I think, what Peter Jones was referring to in terms of many dietary modifications, folate supplementation have been shown to affect epigenetic pathways and would be candidates for trying therapies. And in the past, we would be a little bit blind in terms of measuring what effects they might have. But now that we know to look at, for example, DUX4 expression or DUX4 methylation or some of the epigenetic changes, one could revisit some of these dietary or exercise ideas and use molecular markers to try to determine whether they're being effective at the level that we're trying to affect.
Okay, so how does it work? Is it working? Yes, thank you. As you might recall my last drawings of a cell with the Wnt pathway and the oxidative stress pathway. So DUX4 induces oxidative stress, as Michael Kyba just confirmed, and oxidative stress is inducing muscle atrophy. So that was the idea of Dalila Laouj in Montpellier University in the south of France, to develop antioxidant clinical trial. And so she has one publication. The first author is Turkey, Turki, which demonstrates the oxidative stress at different levels in muscle biopsies, in blood samples, and mitochondria activity. And they have done the clinical trial. They have it was a double-blind placebo, and they have more than 50 individuals who were in the trial. And they basically are finishing writing the paper with the report on what happened, and should be published soon. But basically, in a number of patients, it improved. For instance, they feel less fatigue. They feel less pain, they regain a little bit of strength, and it sort of slows down disease progression. Now, from everything that was said earlier, DUX4 is a chef which is acting on several chefs, and each chef has a cascade of bad events that will take place in the muscle cells. So oxidative stress is only one of those pathways. It clearly is linked to muscle atrophy, so it's very good news that if you can block it, you will stop the muscle atrophy, and normally muscles should be able to repair. But as Michael Kyba presented, DUX4 is also causing problems in muscle differentiation, so in muscle repair. So it's not clear whether just blocking the oxidative stress might be sufficient. It will probably stop disease progression, but will it allow repair to occur is really unclear. So we should wait to have this publication out to really look at what's happening.
Hi. First, thank you very much to all the panelists. I'm not sure who to direct this question to, but from my understanding of like a disease like Alzheimer's, where they found a target like beta amyloid and they wanted to take either a small molecule at first or went later to something more targeted like a monoclonal antibody. I was wondering, after hearing all the three panelists, has there been some consideration done for future of some kind of almost titratability of more targeted therapy, where like maybe a monoclonal antibody could be used to modulate DX4, DX4C, or even beta-catenine?
I think that in general, I think the idea you're bringing up is one that is on the forefront of everyone's mind. How can you specifically target a pathway now that we know what those pathways are? And I guess just to step back a little bit, a few years ago, unlike in Alzheimer's where you knew it was the beta amyloid that was causing the problem, we didn't know that. We now know what the players are, and so we can do targeted therapy design. I think that I don't know specifically whether an antibody would be useful because these are intranuclear proteins and pathways. There are mechanisms of getting antibodies into cells and into nuclei, and so it would be feasible to do. But so I guess the general answer is yes, doing the rational targeted therapies like that is now feasible to do, and there are many groups trying different approaches to target different aspects.
Hey, so the therapies that we're discussing are effective on presenting symptoms. So my question is, are these therapies theoretically prophylactically effective on an asymptomatic subject?
Yeah, I'll take that. I think there is no therapy yet, right? So there is no therapy that's been validated, and so I think it's really important to do these trials and to wait to see what results are published after the trials are done before we think about putting ourselves in the position of one or another type of therapy. But from your general question about does a therapy prevent onset in addition to progression, one that targets the key pathway in the disease, you would expect it to prevent onset, yes. And then the other side of that question is there a downside? Say it's a drug that we know targets DUX4. Is there a downside to taking that drug before you have symptoms, or if you actually don't know if you're going to develop symptoms until if you're ever going to develop them, or if you're going to develop them at some later stage? Because as you heard from the morning session, there are lots of people who do the genetic test. When we do the genetic test on their DNA, we find that they look like they could be FSHD patients because of the mutation being present, and yet they're not. And we don't fully understand why it's only a subset of people with this contraction that get FSHD. So, any drug that you take is going to have negative consequences in some small component of the population, and maybe in every individual, depending on the drug. So, so the question of whether to undertake a therapy prior to having any symptoms is kind of a difficult one. And I would just leave you with the idea that as was said earlier, the early therapies are likely, I think Dr. Vandermarl mentioned, the early therapies are likely to be kind of very generic interventions like diet and exercise and perhaps antioxidants. But those having the right diet and getting the right amount of exercise to stay healthy, to not make yourself sicker, than you would otherwise be, are really good ideas regardless of being affected by a particular genetic disease. Does that answer your question?
Someone was talking earlier about late onset symptoms of FSHD. Is there any studies being done or any comparisons being done of comorbidities that might either be caused by FSHD or affected as far as symptoms go as you get older?
I don't know, the clinician.
I can just give a general response to that. Those are very important questions, and I think that they will be good to look at. And it comes up particularly with the identification of SMCHD1 as causing FSHD2, and whether that's associated with any other diseases in the population as well.
And a corollary to that, if you test all these compounds which show improvement in the disease, there's also compounds that make it worse. So that being said, are there medications that people take that will make the disease worse, or at least the symptoms worse? For instance, calcium channel blockers and that kind of thing.
Again, I think that's a very, very important question, and as we identify the pathways and how drugs affect them, it will be critical to look at that, but I don't have a better answer to that right now.